Test. Hi, thank you for coming. We're just going to wait for a couple more minutes just to see if anyone else comes in. Thank you. Hi, so we're going to get started. My name is Katie. I'm one of the PGY1 pharmacy residents. Today we're going to be talking about the most recent community-acquired pneumonia treatment guidelines from 2019 by the American Thoracic Society and the Infectious Diseases Society of America, as well as looking at some new treatment approaches approved for the indication of community-acquired pneumonia. Before starting, I want to state that I have no financial interests or affiliations, and brand names that I use throughout the presentation are for informational purposes only. So in terms of pharmacist objectives for today, we're going to list common organisms involved in the pathogenesis of community-acquired pneumonia. We will identify risk factors for infection caused by Pseudomonas and methicillin-resistant Staph aureus or MRSA. We will describe the differences between the treatment of outpatient and inpatient CAP. We will select appropriate antimicrobial therapy based on isolation of a specific organism. And finally, we will name examples of new antimicrobial agents for the treatment of CAP. So before we dive straight into CAP diagnosis and the treatment regimens, it's important to understand its epidemiology and pathogenesis. So as we know, treatment of CAP can range from the outpatient setting to the inpatient setting. So we see patients with CAP present to an outpatient clinic to be evaluated, while other more critically ill patients may be so sick that they require hospitalization or even an ICU admission. I also wanted to point out that CAP has been associated with a high mortality rate, especially in patients admitted to an ICU. It is the 8th leading cause of death overall and the leading cause of death due to infectious disease. And CAP can be a concern in terms of hospitalization, mortality, and healthcare costs. So now that we know how serious of an infection CAP can be, what exactly is it? So CAP can cause mild to severe illness in people of all ages. And in CAP, pathogens that colonize the pharynx are microaspirated into the lower respiratory tract, and this can cause an infection of the pulmonary parenchyma, and this is what we know to be as pneumonia. In the setting of infection, pneumonia can occur if the host defense is overcome due to the bacterial load itself or due to the disease severity. CAP itself is a term describing pneumonia acquired from an everyday setting that does not include exposure to a hospital, nursing home, or other healthcare center. This is more of the definition for healthcare associated pneumonia, or HCAP. All right, so what is HCAP? In the old guidelines from 2007, HCAP was a classification of pneumonia that was recommended by the guidelines. However, in response to this release of the guidelines, we saw an increase in the use of broad-spectrum antibiotics without improved patient outcomes. So in using such broad-spectrum antibiotics, we worry about the emergence of resistance as well as the incidence of C. diff infections. So based on this low rate of improved outcomes, as well as concern for resistance and C. diff infections, the HCAP category was completely eliminated in the 2019 version of the CAP guidelines. So here on the slide, I just have listed some of the most common organisms implicated in the pathogenesis of CAP. And of the organisms listed here, the most common bacterial organism identified in the United States is Strep pneumoniae. This organism can be of concern because of the emergence of resistance, and this should be kept in mind when selecting antimicrobial therapy. I also wanted to note some of the atypical organisms that I have listed here, such as Mycoplasma pneumoniae, Legionella species, and Chlamydia pneumoniae. And the presence of atypical organisms as common pathogenic organisms guides our selection of antibiotic therapy as well. Finally, we should recall that besides these bacterial organisms, the influenza virus is also a common cause of CAP as well. So now that we know more about CAP itself, how does it present in the patients we see and how is it diagnosed? Here on this slide, I have listed some common signs and symptoms that we might see in patients presenting to the clinic or the hospital with suspected CAP. And of these listed here, we're probably most familiar with the symptoms that I have listed in the top row. In addition to our patients' clinical presentations, laboratory and radiologic findings are used to diagnose CAP. So laboratory findings are used in order to confirm inflammation and assess the severity of the infection. And additionally, with these laboratory findings, we can dose our antibiotic regimens appropriately. Radiologic findings are used to identify an infiltrate or effusion on a chest x-ray, which can be indicative of an abnormal substance within the lungs alveoli. So now that we have a working diagnosis of CAP, we need to be able to classify it as non-severe or severe in order to guide our decisions in obtaining cultures as well as in selecting antimicrobial therapy. So before I go into the criteria that's specifically mentioned in the guidelines, I thought it would be easier to quantify it by linking it to the SIRS criteria that I have listed here. And this is the systemic inflammatory response syndrome criteria. And this criteria focuses on hypo and hyperthermia, tachycardia, tachypnea, and leukocytosis or leukopenia. So as we can see here in the guidelines for the classification of severe CAP, we can see that some of our SIRS criteria have transferred to this criteria. And a patient is considered to have severe CAP if they have at least one of the following criteria in the major section, or at least 3 of the criteria in the minor section. And based on our classification, we can now decide whether or not to obtain cultures as well as select appropriate antibiotic therapy. So now that we've diagnosed our patient with CAP and determined the severity of their CAP in order to guide treatment, we now have to figure out if we are treating them as an outpatient or as an inpatient. Additionally, keep in mind, if they do end up being treated as an inpatient in the hospital, we need to determine their level of care that they require, whether it be a regular medicine floor or ICU level of care. The Pneumonia Severity Index score, or the PSI port score, considers the patient's subjective and objective findings and assigns them numeric values. So this could be the patient's past medical history, temperature, heart rate, respiratory rate, or other serum chemistry findings. After obtaining our patient's score by adding up all of their numeric values, we can use this score to interpret which setting they should be treated in. And as you can see here, as our patient's score approaches 90, we start to consider admitting them to the inpatient setting. Another type of scoring system used for CAP is the CURB 65 score. This considers the patient's mental status, age, and other objective findings listed here and assigns them each a value of 1 point. In the chart below, we see that lower scores indicate outpatient treatment and higher scores suggest inpatient treatment. When our patients land in the 2-point category, we can use our clinical judgment to determine whether they should be treated as outpatients or if we should admit them to the hospital. So like I said before, when using scoring systems to assess our patients, we also need to employ clinical judgment. So in general, the PSI port score is recommended over the CURB 65 score. And this was due to the fact that 2 multi-center cluster randomized trials demonstrated that the PSI port score safely increases the amount of patients who can be treated in the outpatient setting without worsening their mortality or other clinically relevant outcomes. Ultimately, the PSI port score showed decreased unnecessary admission rates, decreased high costs associated with pneumonia treatment, and reduced risk of hospital-acquired complications and infections. In the hospital setting, I also wanted to point out that direct ICU admission is automatically recommended anytime there's a patient with CAP that requires vasopressors or mechanical intubation. And this is because it was found that patients that are transferred to the ICU after an admission from a general medicine floor experience higher mortality rates than those directly admitted to the ICU from the emergency department. So after we have our patient that's diagnosed with CAP, what other measures should be taken before starting them on antibiotic therapy? Typically in the outpatient setting, gram staining is not recommended because of its lack of demonstration of better outcomes shown in studies. In the outpatient setting, blood cultures are also not recommended due to the lack of high quality studies as well as the incidence of false positives. However, as we approach the inpatient setting in certain situations, obtaining gram stains and cultures is recommended. And these are for the scenarios that I have listed below, which mainly pertain to severe CAP as well as risk factors for acquiring an infection by a resistant organism. So this recommendation differs from the 2007 guidelines because back then patients receiving MRSA or Pseudomonal coverage were not eligible for pre-treatment gram stains or cultures, but now in the 2019 guidelines, as soon as a patient is receiving coverage for MRSA or Pseudomonas, they are eligible for gram staining and cultures as well. Another measure that healthcare professionals may consider in the setting of suspected CAP is obtaining serum procalcitonin levels. Regardless of serum procalcitonin level, empiric antibiotic therapy in patients with suspected CAP is recommended. Generally, when we think of procalcitonin, levels less than or equal to 0.1 micrograms per liter indicate a viral infection, while levels greater than or equal to 0.25 micrograms per liter indicate a high likelihood of bacterial pneumonia. However, these findings were not found in a recent study that was done. The reported sensitivity range of 38% to 91% indicates that procalcitonin's ability to detect a true bacterial infection can fall within this wide range as well. And due to this wide range of sensitivity, procalcitonin alone cannot be used to justify withholding antibiotics from patients with CAP. So now that we are familiar with the diagnosis and classification of CAP, we can use what we learned in order to guide our selection of treatment regimens. Before going into any of the treatment regimens themselves, I wanted to highlight the recommended duration of therapy for CAP overall. So in general, treatment should continue for at least 5 days and then be reassessed based on the patient's clinical picture. Randomized trials showed no difference between treatment using cefuroxime for 5 days versus 8 days, as well as in a situation using ceftriaxone for 5 days versus 10 days. If the patient is not stable after 5 days, they should be reassessed for alternative sources of infection, pathogens resistant to current therapy, and complications such as empyema or lung abscess. In patients suspected or proven infection with MRSA or Pseudomonas, treatment duration should automatically be at least 7 days. Several recent meta-analyses similarly demonstrated the efficacy of shorter antibiotic therapy of 5 to 7 days. So here I have the guideline recommended treatment regimens for treating CAP patients with no comorbidities in the outpatient setting. In this setting, we can treat CAP using monotherapy with either amoxicillin, doxycycline, or macrolides at their respective doses. The new guidelines recommend the high-dose amoxicillin as the first-line agent for CAP. In terms of macrolide monotherapy that I mentioned in the previous slide, there is actually not a strong recommendation for this treatment regimen. This is due to the fact that there are resistant rates of over 30% among strep pneumoniae isolates in the United States. Additionally, there was a cohort study done that detected that during 5 days of azithromycin therapy, there was a small absolute increase in cardiovascular deaths, mainly seen in the elderly population. So based on these findings, monotherapy is only recommended where resistance is documented to be low and alternative therapies can't be used, such as in the setting of drug allergies. Before I transition to treatment regimens for outpatient CAP in patients with comorbidities, I wanted to highlight exactly which comorbidities are mentioned within the guidelines. These populations have been shown to have an increased risk for poor outcomes. Additionally, I wanted to point out that likely organisms implicated in CAP can vary between disease states. An example of this is in patients with COPD. In this disease state, organisms such as Staph aureus and gram-negative bacilli are actually the most common causes of CAP, in contrast with what is normally the most common causes of CAP. So in contrast to patients without comorbidities, patients with comorbidities should receive broader treatment because they may have risk factors for antibiotic resistance due to previous contact with healthcare settings or prior antibiotic use. These recommended regimens differ from the 2007 guidelines because the use of high-dose amoxicillin is removed, and basically what you're left with is the use of Augmentin. The role of beta-lactams in combination therapy is to target strep pneumoniae that may be resistant to macrolides or doxycycline. So this is the rationale behind combination therapy. Other factors that we should keep in mind when selecting appropriate regimen include drug allergies, presence of arrhythmias, and vascular disease. In the setting of arrhythmias, beta-lactam plus doxycycline would probably be the best choice due to the QT prolonging effects associated with macrolides and fluoroquinolones. In the setting of vascular disease, beta-lactam plus macrolide or doxycycline would be the best choice due to the risk of aortic aneurysm seen with the fluoroquinolones. So I have our first practice question here. HP is a 28-year-old female with a past medical history of eczema, presenting to an outpatient clinic with 3 days of fever, cough, and chills. She develops hives when given fluoroquinolones. Based on other clinical findings, the physician diagnoses her with pneumonia. Which of the following treatment regimens would be most appropriate to recommend for HP? So yes, the answer is C here. A is incorrect. As I mentioned before, macrolide monotherapy is only recommended when you have documented low resistant rates in the community, and if the patient has a reason that they cannot receive other therapies that are recommended. B is incorrect because not only does HP have a fluoroquinolone allergy, but fluoroquinolones are not recommended in the treatment of outpatient CAP in patients with no comorbidities. D is incorrect because this is a guideline recommended regimen for patients with comorbidities. All right, so I have our next question. GM is a 55-year-old male with a past medical history of atrial fibrillation and type 2 diabetes. In the outpatient clinic, he complains of persistent cough, chills, and myalgia. Later, he is found to have pneumonia. Which of the following treatment regimens would be most appropriate to recommend for GM? So yes, D is the correct answer here. A is incorrect because the patient has comorbidities, so they require a more broad approach to their treatment regimen. B is incorrect because GM has atrial fibrillation and levofloxacin can prolong the QT. The same case as in C, where azithromycin also causes QT prolongation. And D is appropriate because it contains agents that do not prolong the QT, as well as containing broad agents for patients who have comorbidities. So now we're going to be transitioning from the outpatient setting to the inpatient setting. Based on our criteria from earlier, if we diagnose someone in the hospital with non-severe CAP, how would we go about treating them? So the main difference between the treatment of outpatient and inpatient CAP is that we lose the use of doxycycline in the inpatient setting. Additionally, in contrast with the outpatient setting, the beta-lactams recommended here in the inpatient setting are available in IV formulations. I want to call attention to the drug ceftaroline, which possesses MRSA coverage. So in patients with concern of MRSA infection, this would be an appropriate choice without having to consider vancomycin necessarily. Additionally, you should remember that if ceftaroline is used, then the collection of gram stains and blood cultures would be recommended as well. So if we have a patient that cannot use macrolides or fluoroquinolones, such as in cardiac arrhythmias, like we talked about before, beta-lactam plus doxycycline would be an appropriate alternative, although not recommended as initial treatment in the guidelines. All right, so now what if our patient has criteria that pushes them into the category of severe CAP? How would we treat them? As compared to inpatient non-severe CAP, when treating inpatient severe CAP, we lose the option of monotherapy completely, and we are limited to combination therapy. We want to try as much as possible to use the beta-lactam plus macrolide combination therapy, as there was a meta-analysis of 10,000 critically ill patients with CAP which identified that macrolide-containing therapies were associated with a significant mortality reduction compared to therapies that did not contain macrolides. Additionally, in patients who are not able to take macrolides or fluoroquinolones, we need to assess the risk versus benefits of treatment, as doxycycline is no longer recommended in treatment of patients with severe CAP in the inpatient setting. This is because doxycycline use has not been studied in this specific disease state. Okay, so CP is a 62-year-old male with a past medical history of hypertension, presenting to the ED with fever and coughing for 5 days and wants to get tested for COVID-19. Instead, his SARS-CoV-2 PCR is negative, and he is actually found to have bacterial pneumonia. After he is admitted, which of the following treatment regimens would be most appropriate for CP's non-severe CAP? All right, so yes, A is the correct answer here. B is incorrect because in non-severe inpatient CAP, patients should not receive macrolide monotherapy, as I said before. In this situation, a beta-lactam should be on board as well. C is inappropriate as ciprofloxacin is not recommended in the guidelines for the use of CAP because it does not cover strep pneumoniae. D is also inappropriate because of its treatment duration. As I said before, CAP should be treated for a minimum of 5 days. So therefore, A is the appropriate recommendation, as in non-severe CAP, fluoroquinolone monotherapy is an option in the guidelines. All right, so RZ is a 71-year-old male brought in by EMS after being found unconscious at his home. He was found to have acute hypoxic respiratory failure and was intubated in the ED. Chest x-ray shows bilateral pleural effusions. Which of the following treatment regimens should the team consider to treat RZ's severe CAP? Okay, yeah, so B is the correct answer. So A is incorrect because in the setting of inpatient severe CAP, beta-lactam must be given in conjunction with a macrolide. Just recall that I said before that when we're treating severe CAP in the inpatient setting, we lose monotherapy completely. C is also inappropriate for the same reason that I said before, because fluoroquinolone monotherapy is not recommended. And additionally, this is the same issue with D. There is no macrolide on board. So B is the most appropriate choice to treat this patient. All right, so although we just reviewed the basic treatment regimens for different types of outpatient and inpatient pneumonia, in practice, there may be some cases that require special considerations when obtaining cultures or selecting treatment regimens. Before getting into the specific MRSA and Pseudomonas recommendations, I want to highlight the individual patient risk factors for CAP caused by MRSA and Pseudomonas. So here, as you can see, these are patients with prior infection with MRSA or Pseudomonas, patients hospitalized within the last 90 days, and patients who received parenteral antibiotics in the last 90 days. So as I previously stated, obtaining gram stains and cultures are always recommended in patients who are being treated empirically for MRSA or Pseudomonas. Additionally, while obtaining cultures, empiric coverage should be continued while cultures speciate and susceptibilities come back. Recent observational and retrospective studies in CAP patients found that de-escalation of antibiotic therapy at 48 hours in patients whose results don't yield MRSA or Pseudomonas is safe and reduces duration of antibiotic treatment, their length of hospitalization, and complications of broad spectrum therapy. So on this slide, I have some scenarios that were mentioned in the guidelines for MRSA and Pseudomonas and the respective actions that should be taken in each setting. So in the setting of non-severe CAP in patients with recent hospitalization or parenteral antibiotic use, extended therapy is not warranted, as these patients who are stable enough can be easily escalated if necessary. However, in this situation, a case can be made for extended therapy if a patient actually had a previous isolation of MRSA or Pseudomonas. In contrast, in the setting of severe CAP, extended spectrum therapy is warranted because our patient is now critically ill. And finally, when surveillance MRSA nasal swabs are used, they provide benefit as negative predictive values and can help to rationalize the de-escalation from a medication being used to cover MRSA. So in 2013, there was a study evaluating the use of MRSA PCR nasal swabs in patients with pneumonia. In centers with a moderate background prevalence of MRSA pneumonia, nasal swab MRSA PCR testing showed a 98.4% negative predictive value for CAP, meaning that a negative result of this test can be used to rationalize the idea that MRSA coverage is no longer needed. So here I have listed some common agents used to cover MRSA and Pseudomonas. I also want to point out for a disease such as CAP, The vancomycin trough monitoring should be done in conjunction with targeting a 24-hour AUC of 400 to 600 based on the new vancomycin monitoring guidelines. Keep in mind that at Stony Brook, susceptibilities for imipenem and meropenem against Pseudomonas are actually only 72 to 73%. So at our hospital, carbapenems may not be an optimal choice for empiric Pseudomonas therapy based on our local data. Recall that we should be de-escalating to standard CAP therapy if cultures do not reveal a drug-resistant pathogen and if the patient is clinically improving at 48 hours. Okay, so aspiration pneumonia is described by the inhalation of gastric contents into the lungs. And actually, anaerobic coverage for aspiration pneumonia is not recommended, as many patients see resolution of symptoms within 24 to 48 hours and only require supportive treatment without antibiotics. Recent studies have shown that anaerobes are uncommon in patients hospitalized with suspected aspiration pneumonia. Additionally, we want to avoid unnecessary antibiotic use due to increasing prevalence of antibiotic-resistant pathogens and complications of antibiotic use. All right, so besides bacterial causes, we need to remember that influenza is still one of the major causative agents of CAP. During times of low influenza activity, testing can be considered, however, may not be routinely performed. So what should we do if our patient has an influenza pneumonia? Anti-influenza treatment such as oseltamivir was found to decrease the duration of symptoms and the likelihood of lower respiratory tract complications. Anti-influenza treatment reduces the risk of death in patients hospitalized for CAP who test positive for the influenza virus. Treatment within 2 days of symptom onset or hospitalization was found to result in the best outcomes. However, the data still supports starting treatment later on in the disease course. So, although influenza pneumonia is caused by a virus, antibiotic treatment should still be continued in the setting of influenza pneumonia. This is because there's evidence that bacterial pneumonia can occur concurrently with influenza virus infection or present later as worsening of symptoms in patients who are recovering from their primary influenza virus infection. Some common bacterial organisms associated with influenza pneumonia include Staph aureus, Strep pneumoniae, H. influenzae, and the group A strep. So it is important to maintain the guideline recommended standard antibacterial treatments. All right, so now that we have a good handle on the treatments recommended in the ATS-IDSA guidelines, we can now tackle new medications that have been recently approved for use in CAP. The first new drug that we're going to talk about is lefamulin or Zynleta. And I have listed here on this slide and the next slide its approval date, class, dose, mechanism of action, spectrum of activity, and pricing at Stony Brook. One thing to note here is that this medication is available in an oral and IV form, making it easy to transition from IV to PO. So basically, in terms of its mechanism, the binding pocket of the ribosome closes around the medication's mutilin core for a fit that prevents the transfer of bacterial RNA. In terms of its spectrum of activity, lefamulin exhibits activity against Strep pneumoniae, as well as the atypical organisms we mentioned before. The LEAP-1 trial was a phase 3 trial conducted to assess lefamulin's early clinical response rates and investigator assessment of clinical response. Patients were randomized 1-to-1 to receive either intravenous lefamulin or moxifloxacin. Lefamulin was found to be non-inferior to moxifloxacin for the primary efficacy endpoints of early clinical response rates and investigator assessment of clinical response. And it was additionally generally safe and well tolerated in the study. In the LEAP-2 phase 3 trial, lefamulin was assessed for early clinical response at 96 hours. Patients were randomized 1-to-1 to receive oral lefamulin versus oral moxifloxacin. So it differed from LEAP-1 in the sense that it was assessing the oral medication versus the intravenous one. Among patients with CAP, 5-day oral lefamulin was found to be non-inferior to 7-day oral moxifloxacin. with respect to early clinical response at 96 hours after the first dose. So our next drug is omadacycline, or Nuzyra, and it is a newer tetracycline approved for CAP that works by a similar mechanism of action seen in the tetracycline class. It is important to note that the treatment duration for this medication is actually 7 to 14 days in CAP. And this differs from the minimum of 5 days of treatment that I mentioned earlier that was recommended in the guidelines. Also, I just wanted to point out that like lefamulin, omadacycline is available in both an IV and an oral form. In terms of its spectrum of activity, omadacycline is similar to lefamulin in its coverage of strep pneumoniae, as well as atypical organisms. In the guidelines, omadacycline was recently reported to be equivalent to moxifloxacin as monotherapy for adults with non-severe CAP and is effective in the setting of tetracycline resistance. However, omadacycline in the end was not recommended by the guidelines because its efficacy is only mentioned in a single report and its safety information is not as well established as the efficacy data. So this efficacy data was from the OPTIC trial, which was a phase 3 study conducted to assess early clinical response and rates of investigator-assessed clinical response with omadacycline use. Adults with CAP were randomly assigned 1-to-1 to receive IV omadacycline or moxifloxacin. Additionally, a transition to oral therapy was allowed after 3 days of IV therapy. Here, omadacycline was found to be non-inferior to moxifloxacin for the treatment of community-acquired pneumonia in adults. And finally, our last drug is delafloxacin, also known as Baxdela. This is a newer fluoroquinolone approved for CAP that works similarly to the other fluoroquinolones and is also available in an oral and IV form, just like the other new medications that were recently approved. Mechanistically, delafloxacin works by inhibiting DNA gyrase at the topoisomerase 2 and 4 enzymes. In terms of its spectrum of activity, delafloxacin is different from lefamulin and omadacycline because it covers Pseudomonas in addition to strep pneumo and the other atypical organisms. The DEFINE CABP trial was a phase 3 trial conducted to assess early clinical rates of delafloxacin. Patients are randomized 1-to-1 to either delafloxacin or moxifloxacin. Patients were able to switch to oral therapy after a minimum of 6 IV doses. And in this study, since non-inferiority of delafloxacin compared to moxifloxacin was demonstrated, intravenous and oral delafloxacin monotherapy was found to be effective and well tolerated in the treatment of adults with CAP. So there are some very promising antibiotics that have recently been approved in CAP. Actually, delafloxacin has been associated with lower rates of C. diff than the other fluoroquinolones. Okay, so in conclusion, just to sum everything up, we now know that there are treatment regimens specific to outpatient or inpatient settings, and regimens can be further tailored based on the patient's comorbidities, severity of disease, or specific pathogens. More recently, new treatments are being investigated and approved due to rising resistant rates, especially in the macrolide class, as I mentioned before. And this also gives us more treatment options in patients who may not be able to receive the current guideline recommended therapy. And the point that I want to conclude with is that when treating our patients, we need to keep in mind that we must be an advocate for our patients while also being actively involved in antimicrobial stewardship in order to optimize their medication therapy. Okay, so now I'll take the time to take any questions if you guys want to just put them in the chat.